I was sort of tasked with giving kind of a few slides, and I sort of thought of this as asking some of these, what I call sort of Talmudic questions about this disease. I have many more question marks in these slides than I have answers, but I think highlighting some of the things that were shown much more eloquently by these parents about things that we're seeing in some of the patients that we don't fully understand and don't necessarily know how to best treat and manage. So, starting with this idea of complicated or refractory systemic JIA, when we look broadly at patients with systemic JIA and we compare it to where things stood, even 10 years ago or 15 years ago, outcomes overall have markedly improved with introduction of these anti-cytokine blockers. I think about my partner, Dan Lovell, who said when he started at Cincinnati, they met monthly with the orthopedic surgeons to plan joint replacements. And I can think of 2 patients I know of who've had joint replacements in the 11 years I've been at Cincinnati. However, as we just saw from some of our family partners, there are patients who fail to respond or have these very complicated treatment courses, which can include a number of different features that were highlighted by these parents here. When we met in 2019, we, as a group, including parents, workshopped this sort of definition of what is refractory systemic JIA. We also came up with this definition of what we ultimately unsatisfyingly called persistent partial MAS, or smoldering MAS, which I like better, actually, because it's a little bit more evocative. And so, showing how we can at least begin to define what we're talking about. But what I've sort of wondered is what really is this biologically? So are patients with refractory systemic JIA, are they just the sickest patients with this disease? And it's the same underlying disease mechanisms as the patients who have a more typical course, but our treatments just aren't quite strong enough. Or is this really a different disease phenotype? And these are really different disease pathways and needed to be treated differently. And that's why our first-line anti-cytokine therapies are not working. Are there patients who those medicines would work, but for whatever reason, they're having drug reactions or side effects, and they're just not able to tolerate those treatments, which would otherwise be able to control the disease? Or, and most concerningly, are some of these things that we're seeing actually complications that are made worse or even caused by the treatments that we're using? And so we've heard about some of these sort of newer refractory disease courses. And again, I didn't know anything about what the parents would be sharing, but really they're talking about everything that I'm about to talk about. This recognition of inflammatory bowel disease or Crohn's disease in patients, again, vanishingly rare prior to 10 or 15 years ago. I've seen a couple of new patients with this just in the last year. This was a very nice case series led by our good friend Betsy Mellons, who described 16 patients with this complication, compared them to those otherwise in the CARA registry, showed that these patients were generally older, they have more MAS, they have more family history of IBD, they are more non-white race, and then many of them seem to then transition after diagnosis to TNF blockers and do well on that therapy, as opposed to sort of the IL-1 or IL-6 blockers that most of them were on prior to diagnosis. And then certainly lung disease, which we're going to talk a lot about. What we call lung disease or systemic JIA-LD likely encompasses several distinct disease mechanisms. This was actually laid out very nicely in the Saper and Mellons paper from 2019 of some of the different patterns that we see on biopsy and on CT. But the most common phenotype that we see is this sort of early onset disease, very high IL-18, this development of this sort of acute erythematous clubbing of the digits, CT findings showing this sort of initially pleural-based or septal perivascobronchial thickening. If they are biopsied, we see this sort of inflammatory infiltrate in the lungs, along with this PAP or endogenous lipoid pneumonia on the biopsy. And these patients have almost exclusively, but not fully exclusively, had exposure and sort of failure to control the disease and or possible drug reactions to anti-IL-1 and anti-IL-6 blockers. And again, this sort of phenotype shown here in this figure from Betsy and Vivian's paper, showing that that is sort of increasingly reported starting around 2012 or so. How prevalent of this is this? Well, that depends. When we published our paper in 2019, we looked at all of the patients that we primarily followed at Cincinnati, excluding patients like some of the ones here today who came to Cincinnati because of our expertise. We found a prevalence of about 6.5% or 7%, which people were shocked by initially and said that is high. We look at the Dutch cohort, and it's lower, but maybe becoming more prevalent. But then a recent paper from some of our Chinese colleagues, which showed that almost 20% of their patients in 2 large Chinese centers actually had lung involvement. And so maybe our number isn't quite so off. And then, so I've sort of wondered, is what we call the systemic JIA lung disease, are these patients really a distinct phenotype from what is typical systemic JIA? And, they're much younger at age of onset. They have higher levels of IL-18 at diagnosis. They have, if we look at sort of their immune landscape, we see different cellular patterns, particularly in the T cell compartment from other SJIA patients. They have this higher incidence of MAS, including this sort of smoldering MAS, this strong association with Down syndrome, and then this HLA association. And then these sort of idiosyncratic or atypical responses to biologics. The age thing is very striking. So this was done by our former fellow Shima Yazin several years ago, where we matched the first 18 patients we saw in Cincinnati by their current age and by their biologic sex to patients who did not have lung disease who we followed. And you can see the bottom graph. This is what you would find in a textbook. If you say, well, what's the age of onset? If you ask generative AI, what's the age of onset of systemic JIA, you would get this graph, right? A sort of a broad peak in early childhood. But if we look at our lung disease patients, it has a big shift. And that can't be due to treatment or something like that. This is the phenotype of this patient, and so there is something fundamentally different about this phenotype of patient. What about rashes? We've talked about itchiness. These are definitely concerning features, but maybe they're not always dress. This was a very interesting paper from the French, where they looked at 30 patients with atypical rashes, and I think it's about 80 or so, I forgot to look that up apparently, with typical Still's disease rashes. They found that these patients had higher inflammatory markers at onset, they had more onset, more failure of treatment, and more likely to have a persistent disease course of still needing biologics 2 years out from diagnosis. And finally, what is this HLA-DRB marker, which we're going to talk a lot about, and Mike is going to, who's really the most knowledgeable about this, is going to talk more about this tomorrow. So how common is this in systemic JIA? So when we look at his broad collection, which are patients who met the ILAR criteria, it's about a quarter of all of them, which is similar to the population. If you look at the Dutch cohort, same thing, and no difference whether they had arthritis or didn't have arthritis at onset. And I've always come back to this. Okay, so it's about a quarter, and we also say about a quarter of patients have refractory disease. So, what does the Venn diagram of those look like? And might it approach a circle? And we see when we look at several different studies, we see higher prevalences of this in sort of more chronic and refractory patients. So a study from Lauren and Holly and others in Boston, half of their patients that they genotyped had this. Patients in Minnesota, actually even more of them that they genotyped had this. We're going to talk a little bit about our Accelerate project. We haven't genotyped those systematically yet, but of those who have been genotyped, over 70% of them have this, which are patients with refractory disease courses. So I wonder, could this really be a marker for this refractory disease phenotype, regardless of what it's ultimately doing with relations to biologics? And I'm going to, I think, leave us with that as my last of many question marks that hopefully we will be looking at more today. Thanks.
Our next speaker is Dr. Paul Brogan.
Thanks, Grant, for doing that talk straight after the parents. It's very poignant. I don't think I would have been able to do it. So my job today is to tell you where we're up to in the UK with specific reference to resistant disease. That's not me down at the left. That's anyone know who that is? Full name for full marks? George Frederick Still, and he was at Great Ormond Street, our hospital. Right, how do I do this? Was he a sir? Sir. Okay. Don't worry, I've got no chance of being knighted. So, you know. So shown here is a little cartoon of the trials, the evidence base for treating Still's disease. I prefer the name Still's, but I've called the title Systemic Juvenile Idiopathic Arthritis because the outcomes I'm going to show you are just for children, not adults. A thumbs up means a trial was done and it works, and a thumbs down means the trial was done and it doesn't work. So really the evidence base started in about 2000. Pat Wu did a study. It was a funny study. It was a trial that included patients with Still's disease, but also oligoarticular GIA. And if you read the abstract of that excellent paper, it seems that methotrexate is great, but when you really read the paper properly, it didn't work for the systemic features of Still's disease. So that was in 2000, and that gets a thumbs down. But the NHS in the UK insist that we start treating Still's disease with methotrexate still. And if you're an adult, you have to fail 2 DMARDs before you can progress to biologics. So as we move on through the timeline, in 2005 and 2021 is a timeline that I'm going to describe what happened to the actual patients from our centre, spanning this changing therapeutic landscape. So Pierre Carty did a small trial, but it was a good trial because, you know, small numbers of patients, but it showed an effect of this new medicine, anakinra. So that get a thumbs up, that's great. And then soon after that, we had 2 trials published at the same time. I've put the tocilizumab trial first because I know that Fabrizio was in the audience, but actually they were in the same edition of the New England Journal, weren't they? Tocilizumab and canakinumab. So they get a thumbs up, amazing. And then in 2023, we used emapalumab, again, led by Fabrizio, and we had a trial that for the first time provided an evidence base for how to treat patients who had systemic GIA complicated by the macrophage activation syndrome. So that's all great. But in the UK, it seems that our current government is more interested in money than evidence because we're not allowed to use, oh, beg your pardon, how do I go back? Let's do that. We're not allowed to use, at the moment, 2 of the most important treatments. We cannot have access to canakinumab for Still's disease, and we certainly don't have access outside of clinical trials to emapalumab, leaving us with 3 medicines, one of which doesn't work, and the second one, anakinra, that you're only really allowed to use if the physician thinks there's actually macrophage activation syndrome. And surprise, surprise, there seems to be much more MAS around in the UK. I don't know how that happened. There's the effect of biologics right there. So during this period, 2005, 2021, we decided to take a look at our cohort and find out what happened. So there were 76 cases, and overall, the outcomes were good. At the last review, which spanned between just a few months up to 16 years, 88% had clinically inactive disease. So they were still on treatment, but the physician global assessment and all other markers were down and low. 84% were steroid-free. And 32% we classed as being in remission. In other words, off all treatment, no evidence of active disease. So for those of you who are interested in the window of opportunity, we looked at this. If you began a biologic treatment, any biologic, within the first 3 months from the diagnosis, there were better outcomes at 1 year. So clinically inactive disease in 90% versus 53% at 1 year if you started after 3 months. But in fact, there was absolutely no difference in the longer-term outcomes when we looked, and the majority of patients ended up on a biologic. So to me, this was saying actually, window of opportunity, great hypothesis, not borne out by these retrospective data, and it makes much more sense to use treatments that work sooner rather than later. Don't wait. Okay, what complications did we see? Because within these complications are the refractory disease patients. So suspected MES, there's a new diagnosis for you to get access to anakinra. And history, we'll be on the right side of history with this one. 46% of our patients, and in fact it wasn't just made up, these are patients with hyperferret anemic inflammation, and we teach our juniors, don't wait for all the tick boxes and all the terrible things to happen. Recognise hyperferret anemic inflammation early and jump on it. And so there were 46, at least one episode of suspected MAS throughout the disease course. And the treatments that the patients received in our institute were high doses of glucocorticoids, the most potent anti-inflammatory drug used in the last 80 years in the whole of medicine, still, bar none. Anakinra, cyclosporin, etoposide. I've not heard much talk about etoposide. And some of the stories I've been hearing earlier on this morning, there were definitely patients, if they were under us, that we would have said, oh my goodness, game over, etoposide, fast track to BMT, if we can get them stable. And then, of course, emapalumab or Gamifant. Someone was asking me what's Gamifant. In the UK, we don't use the trade names. We like to use the generic names. So Gamifant, emapalumab, but only in clinical trials. And there were 2 patients in this series that received it and did brilliantly. And we've treated 4 now, all in the clinical trial Part B. So what about bone marrow transplant? Well, during this period, we transplanted 4 patients. When I joined rheumatology in 2004 from nephrology, I was amazed that people were still thinking about autologous transplants, so giving them back the patient's own bone marrow, which made biologically no sense whatsoever. So when I came in, I was absolutely insistent that we drop that and we just focus on allogeneic. And there are only 2 types of bone marrow transplants if you're going down allogeneic, good ones and bad ones. Good ones have a 10 out of 10 match. You might push in a 9 out of 10 match, but anything less than that, these are bad matches. All achieved clinically inactive disease. For SJIA lung disease, there was only 1 patient. But don't think for a minute this is because this has suddenly emerged. We were not looking for it. I heard some of the equipoise in the audience about what test to do in a 6-month-old. It's a CT scan. There is no other test. It's the only biomarker. And there's a bit of reluctance. And that happened historically. This lung complication has always been there. The symptoms on the whole are rather minor. And you may only have clubbing if you remember to look for it. So at least in the UK, I don't think this is a newly emergent phenomenon. I think it's always been there. We just weren't looking for it. In terms of mortality, no patient died during our study, but 1 patient did die, and we reported it in the paper 7 months after the data collection had stopped. And these were stories rather similar to the one that we just heard, with smouldering mass, relapsing, etc. So in terms of resistant disease, the way that I present it to you is think about the different components. So be very clear about which part you think might be resistant. And of course, they all overlap because it's the same disease. So arthritis, systemic inflammation, smouldering, we like that term as well, by the way, or recurrent mass, and of course, the lung disease. Who made it up?
No, we were just wondering about the spelling of the word smouldering.
My spelling is right, I promise you. Okay, so for arthritis, I'm not really going to focus. There are quite a lot of therapeutic options, and you can access many different types of medicines for polyarticular GI, etc. For systemic inflammation, the medicines shown in black are the ones that we can access in the UK, and the ones that are in red we want to access but cannot, at least in the NHS. So anakinra, tocilizumab, as I've said, canakinumab, JAK inhibitors. Now, if you do use a JAK inhibitor, please think about the dose that you're using. There are 2 doses, roughly speaking. There are low doses favoured in tofacitinib, for example, for arthritis, and there are higher doses that are used in monogenetic interferonopathies. And for these severe diseases, think about the higher doses. So for that reason, we like baricitinib in the UK because we have a policy for using baricitinib for monogenetic interferonopathies. If you use ruxolitinib, JAK1/2, also JAK1/2, again, you've got a scope to push the dose up because there's pediatric dosing available. If you use something like tofacitinib, what I never hear when people present this is, yes, we're using super high dose of tofacitinib, much higher than we use for arthritis. So think about the dose. And then obviously cyclosporin, methotrexate, and of course, glucocorticoids. For smouldering mass and recurrent mass, again, in black are the treatments we actually use, and in red, the ones that we'd like to use or in the future would like to at least study. So anakinra, tocilizumab, canakinumab, emapalumab. So I'm very much hoping the combined pooling data of the 2 trials will come and be fruitful, and we'll get access to that. JAK inhibitors again at higher dose. Cyclosporin, glucocorticoids, etoposide. Please don't forget that at some point, if you're not winning, you can say game over and you can treat them with a potentially quite toxic medicine, but it can be life-saving. But usually by that point, it's a bridge to transplantation. And then, of course, you do have allogeneic HSCT, so that's bone marrow transplantation. A lot of talk about anti-IL-18. Alexei was asking me, why do you hate IL-18 so much? I love it. It's great. But it's a great hypothesis at the moment, largely for many of the things that we're talking about. There's been a couple of case reports where people have tried to block IL-18 and it looks favourable, but it always does when you treat the first couple of cases. They're the ones that get published. So let's keep it real. We're trying to get a trial together, but we couldn't even agree on the design of a trial last year. So we're trying hard, but it's not there yet. I'm very interested in MAS 825. So if there's anyone from Novartis here, maybe we can talk later. And then for the lung disease, anakinra and tocilizumab, one of the things that we've not talked about, we talked about all the dress reactions and the controversy around that, but one of the theories I like is from Professor Shimizu, and certainly we have come across this. So these are patients that are grumbling along, high IL-18, maybe develop lung disease, and you decide, right, I'm going to sort this patient out and start them on tocilizumab, and 2 days later they get rip-roaring MAS. And it's to do with this balance of IL-18, the ratio of IL-18 and IL-6. And if you perturb that ratio very quickly, as I was saying yesterday, cytokines are chaotic, you can sometimes tip the balance towards a more MAS immunophenotype and actually induce MAS by rapidly lowering IL-6. So we've certainly come across that, and Professor Shimizu was talking about this some years ago. So I think that requires a bit of discussion about why you would carry on to measure IL-18 if you're thinking about adding in IL-6. I think it's a sensible thing to do. Canakinumab, emapalumab, question mark. Don't know whether emapalumab will be good for the lung disease. Makes sense, but we just don't know. JAK inhibition certainly does. The only patients I've treated have been private patients in the UK who can pay for it themselves. It's about £15,000 a year, something like that. So some people can, and it's awful. We'd like to have access to this medicine for the lung disease. It seems to work in a couple of patients I've used it in, but you know, it's hard to know longer term. And then, of course, for these patients, allo-HSCT, please don't forget about that. You do have an option, and if you wait too long and they're too damaged, they'll be too sick to go in for allo-HSCT. So that's it. Thank you.